My interests, obviously TTP, all TMAs, and also do other rare anemias. I do have a lab, so I do work with a lot of mice. That's my fun fact.
And I'm Yazdan Abou-Ismail. I am an adult hematologist at the University of Utah. My interests similarly are also immune-mediated disorders of coagulation and rare blood disorders such as TTP. Fun fact, I have a rose garden that I obsessively take photos of and maintain, and I play the piano.
All right, go.
I have a question. Have you heard of hormones being linked to congenital TTP?
So, can you repeat that question again?
Have you heard of other patients where there is a hormone link between their TTP and their hormones?
Which particular hormones? Like
I believe probably estrogen and progesterone. Which one's the one that takes over right away when you're pregnant? When you're pregnant, which hormone goes away or lessens? One rises, one lessens.
Yeah, so the question is, are there hormonal influence on TTP in general? Good question. So we haven't seen certainly in congenital TTP because that's a genetic problem where you actually have really no ADAMTS13 or really low ADAMTS13. So essentially, we haven't seen any major changes for the ADAMTS13 because the levels are so low with regards to hormones. Now, there's been certainly questions about in immune TTP because we know there's difference in men and women with regards to hormones. And two, and there's especially, why do some of the adolescent children or adolescents actually present with TTP and not just TTP, other autoimmune diseases? So certainly there's a hormonal influence which happens during puberty. So there's certainly influence, but we haven't really closely studied. The challenges being sort of the rare diseases, it makes it really hard to study such subtle changes secondary to hormones because the numbers who may be studying are usually less than 10 or 20 who may be having this changes of ADAMTS13 levels in relation to hormone. So yes, possible, but we do not have enough evidence to say one way or the other.
To add to that, which may be relevant to your question, is in pregnancy, estrogen levels go very high, and that results in an increase in von Willebrand factor, which is a clotting protein that becomes very large in TTP. So in those who are born with a genetic deficiency of ADAMTS13, aka congenital TTP, that may be part of the reason why a pregnancy can trigger an acute attack, because there's an increased production of von Willebrand factor, which may be excessively large in these patients.
Diagnosed back in 1990 when I got pregnant. I obviously had it my whole life, but I never got treated for it. I just whipped myself back around and went forward. But of my non-pregnancy relapses, all of them happened during either at the beginning, middle, or end of my cycle. All of them. Only 2 times was it based on stress strictly, not that didn't happen during the period. And we know that those were stress brought on. But so my doctor back then told me when I went into, I don't know what you call it, remission or stable or whatever, that hormones or menopause was not going to be my friend, never to take hormone replacement therapy. And that by the time I went into menopause, she was going to be retired. And I missed her by 6 months. She had already gone 6 months before I started relapsing again. So that's why I'm asking, because it's so, and there's so many things for balancing hormones out now, doing for being, chunky or fluffy, or having so many issues, gut issues, etc., that I obviously don't feel like I can take those, because once it's in my body, it's going to have to go through my body. So I'm too afraid to take any of those. And I just wonder if that link is truly there.
And I'm sorry to clarify, if I may ask, do you have immune TTP, acquired TTP, or
Congenital.
you have congenital TTP?
Yes,
I see.
CM-TMA.
So there, and without diving deep and sharing all your information with everyone, because the devil is in the details. But if you had relapses before, during, at the beginning, middle, and at the end of your cycles, then you could make the assertion that it has nothing to do with it. If it happened at any time during the cycle, then it happens at any time.
It was only during those times. It's never not.
But yeah, well then, but that's what I'm saying. There would be no other time if you hadn't gone into menopause. If you would if I'm understanding it correctly, if you would have a relapse of your TTP in the beginning, in the middle, and at the end of your cycle, what other times would there be for a premenopausal woman?
When I'm this is from when I first started in 1990, when I wasn't premenopausal. I was 25.
Right, you were still having your periods.
Yes.
So what other?
The other 3 weeks of the month, I never ever had a relapse. Only
during the okay.
The menstrual
During
the
your
menses period,
We
not
saw you your whole. Okay.
Oh, yeah. I'm sorry.
Okay, that's why.
I understood it the same way.
Like my wife, as with my wife, I cannot read minds, right? So, but I mean, I would take, what I would say usually with one of my patients is that when someone has had either congenital or immune TTP and there's something else that needs to be treated, whether it's hormone replacement, their thyroid, their cholesterol, their diabetes, they need a mammogram, a colonoscopy, I am a big proponent of pursuing standard of care. And it's one thing if we don't have a treatment for something and you cannot get treated. But if someone says, look, doc, my postmenopausal symptoms are killing me. And as an analogy, we see patients who've had blood clots related to being on birth control pills or hormone replacement. And there are many times where we will put, even though it says you can't ever do this again, oh my God, it's contraindicated. No, we will go back and we'll put that woman on estrogen as long as they're on an anticoagulant. If that is what they need, if this is what's needed for quality of life, or to preserve health or prevent disease, and this has been sort of one of my sounding boards, I find no reason to survive TTP just for someone to die of something else that's preventable. To me, that's completely bass-ackwards. And that's not what I want to say out loud, right? So if a woman is just suffering from postmenopausal symptoms, it's one thing if, look, we knew there was nothing that we could do to counteract that increase in von Willebrand factor creation by giving exogenous estrogens. But if we can give recombinant ADAMTS13, I would push towards trying to do something. And I realized if you were told, never do this, this is going to kill you. Okay. But at the same time, I would also say, look, that's advice that was given 35 years ago. Oh, I mean, yes. I mean, I know you're still 29, but still, yes. But, I realized that was said, and for the time that was invariably accurate. But at this point in time, I don't think it's not as though we can't test. I mean, we didn't know about ADAMTS13 in 90. We were testing for it in 95. It didn't, even in 2005. I don't see the benefit of letting someone suffer when you can do something about it. I'll bill you later.
I was on birth control when I first got TT. So I've talked to a lot of people. We all think that it's hormone. And I know that the kids get it without it, but maybe it's different for adults.
And you're congenital as well, or?
I don't know. I never understood all that.
So yeah, congenital means you were born without. You were born without the ADAMTS13, whereas those with immune mediated, for some reason, and we don't know the reason for it, the immune system makes an antibody against this enzyme ADAMTS13. What's the reason that happens? Geez, none of us know. We are not that smart. We're not that good. I mean, if we knew the answer to that, you know, if I knew it, I'd be Nobel Prize winning, Dr. Metjian, right? I mean, because that's like the holy grail of immunology. What causes the body to lose what we call tolerance to self? And in that regard, I am unaware of a direct link between birth control pills and immune TTP. You know, if I had to like, you know, give a yes, no, I would say no, there's not a response. And I'd say that because, you know, it's not like we've got 10 women on birth control pills or 1,000. I mean, millions upon millions of women are on birth control pills throughout the world. And even
I've only had them for 2 months and I've had it for 20 years now.
I would say it was, if I would push to say it's probably coincidental. It just happened to happen. I mean, there's so many women that are on it, and women that I've been.
I'm through menopause myself, so I'm kind of nervous.
I think you should have a good talk with your doc because, again, like I don't think you should suffer with menopause.
I don't
Yeah.
have anybody to talk to. They literally don't know anything about it.
Well, there's this thing called the CM-TMA. It's filled with a. I mean,
But
you
y'all-
know.
Maybe you should come down to Florida where I am and help us.
Where in Florida are you?
I'm in Tampa.
So how do you feel comfortable about driving to Miami?
I do it in a heartbeat.
Okay, Dr. Camilla Mazias. Look on our website. Yeah, I mean, US.
There's somebody that knows what they're doing.
You can reach us out through USTMA and we can get you contact with one of the physicians in Florida.
Go to our website. Go to our website. You'll see the map of the U.S. and yes, yeah.
Yes.
How far are you from Rochester?
I'm 4 hours from Rochester.
It's okay.
Frank, Dr. Frank Aqua. Frank Aqua. Yeah, I'm saying it wrong, but yes, he's in Rochester.
University of Rochester. Yeah.
I mean, go to our website. No, this is, and even then, we get phone calls all the time from people who are, look, I've never seen a case of TTP, or it's been 20 years.
I've never met anybody until today, and I've had it for 20 years.
This is all we do. So yeah. Look at our website.
Started a support group in Tampa. Literally, I'm the only person in it.
Is it any good? Yeah, go to our website, find us. Yes. Go to our website, I mean, you could reach out to us and we can connect you. There's absolutely, and even then, you know, obviously there's people who can't travel. We partner all the time with their local docs. I mean, yeah.
I would love for my doctor to be educated because he really doesn't help me.
He doesn't.
I'm barely get by. So
Give it-
it
well,
would be really nice if somebody actually could tell them how serious it really is.
And I hope you'll find a specialist who will continue to monitor
I
and
have a
follow
guy
up.
who wrote 3
Yeah.
papers on it,
Yeah.
but I just started with him, so I don't know him, and he already isn't listening to me already. Like, I need to be monitored at least every 3 months. He doesn't even want to do that. He doesn't think it's necessary. And I know my body way better than he does. But he won't listen. So this is the problem we're having. Like, literally, I bet you everybody in here has had a doctor that don't listen. And it's very hard to deal with. And they get mad at you because you know more than them. They don't like that either.
Well, I'm glad you're here because we're here to help change that
Yeah,
for you.
great. Maybe I should do that.
Sorry, go ahead.
I have a question.
sorry, gentleman in the back.
I just wanted to add, my wife was first diagnosed with a lot of Facebook support groups that were very helpful. You know, not necessarily for medical advice, but just for comfort and everything like that. We found out about this conference through a Facebook. I encourage everyone.
Yeah, so for the people online who may not have heard, a gentleman in the audience had recommended, said about how his wife, when she had TTP, found a lot of support with Facebook support groups. So
I had a question about pediatric populations with CTTP and how to monitor symptoms before they can talk. Like we have 15-month-old and he's on a TMA, but we don't know. Like he cries a lot. Like he's teething, you know. So I worry if something under the surface is happening, how do we know that it's happening, and until he can communicate that. I'm just saying it's because you do.
No, so this, the question is, how do we monitor a child who has congenital TTP, and especially 15-month-old, because they could be crying? Is it a symptom of TTP? Is that, so what are you trying to find out? Is that right? Great question. And I think the first and foremost is actually listening to parents, because they know the children in terms of what is normal for the child and what is not. So we usually encourage families that if you're unsure, don't just sit and think. If it's okay to wait, just give us a call. And it may take some time for us to kind of get used to, especially if it's newly diagnosed, to understand what is baseline for the child or what's not. And it may require more hospital visits, emergency department visits, seeing a specialist just to understand, are the blood work okay, are the platelets okay? So while it's important to get a balance of being able to have a reasonably normal life, taking care of a 15-month-old at home, and also, continue with the rest of your own work and families and maybe other siblings. But I think it's being able to find a balance, have that ally with regards to maintaining a rapport with your provider is extremely important. Your provider may not be available all the time to talk to you directly, but having a nurse or someone to help you with it. And I think it'll take some time to be able to know that every 2 weeks is sufficient or not. So it's important not to neglect all of this to say this is a normal for the baby. And it's true, because the challenge is that the first year or two, most children get at least 10 to 12 viral infections, if not more, colds and coughs. And the concern we have is that actually triggering a TTP that we do not know, right? And I think, and we can't do testing every week, for example, and the kids who go to daycare have a runny nose all the time, right? So I think it's more of trying to find the balance and having to talk to the physician. The key is also making sure the hematologist who taking care of the child is comfortable taking care of someone with congenital TTP. And reach out to us. We have certain people around the country who do fantastic work, and we're happy to help.
I'd like to know, do you know how long it takes for TTP to manifest itself? Like, is it a month or a week or immediate? Is it, or
It's a good question, because I think there's heterogeneity in how TTP can present. And here I'm referring to immune. I'll get to congenital in a second. But with immune TTP, it could be acute or insidious. Typically, however, most of the time, at least from my experience, it's more of a quick presentation. Oh, I'm sorry. I think more so than often, it's a quick presentation, although there are certain cases, depending on how it happened or what the cause is, it may be more insidious in onset. But a lot of times there is an acute event or an acute symptom that occurs, and then that brings the patient to medical attention. With congenital, it's a different story, because they don't have ADAMTS13 to begin with. And the first attack may present during childhood or during pregnancy later on, or with some precipitating event, which may also kind of make the presentation variable.
There's just one thing I want to add to that. It's difficult for the first time, because it's very common for people to say, oh, when I had that cough, when I was, I had that numbness, that stomach pain, was that my TTP? And it's difficult to say, because there are some people who will tell you, give you a symptom for for 4 weeks. I noticed bruising and bleeding and headaches. But if it's any sort of consolation, sort of like the glass is half full, it seems, the literature sort of supports this, and I've seen this in my practice, is that the second time around, third time around, patients, they know something is wrong. And we're not catching them when their platelets are 5, it's 147. And we seem to be getting them like ASAP early. So what that is, I've never been able to get someone to put their finger on it, but they just tell me, Doc, I need a CBC. Something's wrong. I saw a bruise that doesn't look right. I'm like, okay, what's a CBC among friends, right? And that usually helps. It's like the patient will tell us something is abnormal.
I think the lady over there was next. Yeah.
Always like 11 up. But I have in the middle of the episode, they feel like 5:30. Right now, I just got tested last month, through the Oklahoma study program. Through the last count was like 11.5. I feel tired all the time, and I've asked about it, and only told me it's attributed to the TTP. Is there something else I need to look into, or to understand why? And I'm also on the lupus and the leukemia borderline, but I don't have all the symptoms to be diagnosed for either. Does that make any sense?
And if I may ask for some additional context, you mentioned leukemia. Did you have some sort of? Oh, your mother. Okay.
Yeah. Borderline having it, but not all the symptoms to say that they can diagnose with it.
With
The aches and pains.
for lupus. Okay.
Okay. Okay. And what is what type of TTP do you have? Acquired TTP.
And when you say your white count's elevated, sorry to keep, we're giving you the third degree.
We're obtaining a medical history.
Yeah, yeah. And do you know what type of white cell is elevated? No, because like when they do the CBC with diff, yeah, do they tell you which one? Okay, but, okay. Lymphocytes? Okay. Well,
So-
okay. No, because I mean,
Okay.
yeah, you'll see. And I mean, some people
Yeah.
will have a white count that's like one, it'll depend on what is the reference range. Because if it goes from 4 to 11 and yours is 11.5 and it's been that way for years, pragmatically, it probably would mean nothing. It's just the way the celestial committee designed you, right? And if it's mostly new, I mean, no, granted, if there's other white cells that are elevated, it worries us a little bit more. If there are these eosinophils or basophils or lymphocytes. But if it's neutrophils, we see that. And if I give anyone in this room a bucket of steroids, I'm going to see it go through the roof. Anyone here, if you physiologically shake the bejesus out of them, we see the neutrophils go up, like heart rate, like a blood pressure. So in and of itself, it may not mean much. If anything, for those people who have a slightly chronically elevated white cell count, yeah, how about that? Well, it could just be just the way, I mean, you know, that's just the reference range. And there, okay.
If I'm not in it, so I always running between 11 I started in it. Sure. But ever since the TTP came upon me, I've been like this. So in the doctor told me that's the reason why I said I have the TTP. But I just feel tired all.
Which is,
Yeah, I mean, I think that it is possible. So, I think of your question as threefold. So there's the white cell part, the fatigue part, and your history of TTP. And we do know that TTP survivors are at increased risk of various symptoms, such as fatigue, cognitive impairment, and increased risk of stroke, especially if the ADAM-TS13 did not fully normalize. That being said, fatigue as a symptom is kind of has a broad differential diagnosis. So there's many different things that can cause fatigue. So it doesn't necessarily mean it is the TTP. It should be evaluated in terms of your other conditions, other blood tests, and so on. And whether this is related to the white cell, I think Era covered that. Most of the time, a slight increase isn't worrisome. But of course, if it's if there's a concerning finding, then it warrants further workup.
I don't, show me your CBC with diff and I'll give you a better answer. Yeah.
Yeah.
I mean, because the devil is in the details. Yes.
So recently I went to the eye doctor and she said that I have symptoms of TED and she said that's because it's thyroid disease.
Oh.
And she said that's because of an elevated PTH, but I'm only about a year and a half out from transplant, from kidney transplant. I have HLS.
Okay. Okay.
And I was wondering if, because I'm only a year and a half out from the transplant, could the thyroid disease go away now after my PTH has been like normalized with the kidney transplant? And my latest PTH was in January of this year, and it was 82.6, which is only a little high, but not that bad. I could shut it.
Be careful what you ask for, right? Be careful what you ask for, right?
No, I think so. Let me get this right. So you had atypical HUS. You had a kidney transplant for that. Did you have a thyroid disease before the kidney transplant?
Well, yes, I have a thyroid.
Unrelated to atypical HUS.
Unrelated.
Okay. So okay. So the question is, why do you think the kidney transplant? How is that affected to the parathyroid or thyroid hormone? Just because they're completely two different things. Is that right? Right. Right. Okay. So it was dialysis loop. Secondary parathyroid. So. Okay.
And that's about how high, like how elevated, how long the PTH was elevated. So I'm wondering if now that it's normalized, will the thyroid diabetes, which the only thing that it causes is like bulging eyes. I'm wondering if that will go away.
I'm not an expert in eye diseases at all, but something, because especially if you have changes in the eye that are irreversible, for having this for such a long time, makes it harder for me to think that'll go away. But seriously, your endocrinology doctor and the doctor looks into eyes can probably give you a better answer to this, I'm afraid. Yeah. Perfect. We'll find out someone who goes to OSC later.
Some people have relapse and the two different ones, like the one where you don't have symptoms for but you're absentee. So I've had 3 relapses in 4 years. The first one was, with all the symptoms. The other ones have, every last one of them have been different. So it's kind of confusing sometimes, but tend to look out for the other symptoms for the first time and then the second time. But it's just like going from my regular, like the last one I just came out. And I had, my absentee was a 5. I was feeling fine. I went to the doctor and I was telling him like I was tired. It was really nothing. But for it to be so low, it was just kind of weird. My platelets never dropped after the first one. After that, they always stay like 200, 350. They never drop. Nothing else on my CDC or any of the other tests indicated. Yeah. But I'm just trying to figure out like why there's such the difference. Because I picked up, I was listening, but I missed some of the details earlier about the 2 different.
And just to clarify, so you have acquired or immune TTP, and you had different types of relapse episodes. So clinical relapse is when there's symptoms and the platelets dropped and the ADAMTS13 is low. And a laboratory relapse or ADAMTS13 relapse is when the ADAMTS13 drops, but for some reason it doesn't result in clinical symptoms and the platelets dropping or anything else. Is that what you've encountered? And so your question is, why does that happen, or what to do about it, or both? Yeah. Yeah, I think that's a great question, because we do see that happen, and we do monitor ADAMTS13 because we want to know when the levels drop, and when they do drop, there's a risk of that triggering a clinical episode, meaning causing the symptoms and causing the platelets to drop and so forth. And for that reason, when they do drop, we try to bring them back up. Typically, we use some sort of immunosuppressant, such as a attempt of rituximab or some other medication if that did not work, because we fear that having chronically low ADAMTS13 levels could either lead to a clinical relapse or an acute episode or other symptoms. So whenever possible, if we can bring it up, we try to bring it back up. Why it doesn't always result in a clinical episode isn't really clear to us. Similar to congenital TTP, they don't have an ADAMTS13 for many years, and some of them will have an attack during the neonatal period and others later on or in life. So we don't fully understand that. But at least in the case of acquired, we try our best effort to bring it back up as long as we're not causing too much harm by causing side effects from different medications and immunosuppressants.
One thing I want to add to that, like one of the things that we are learning, I mean, there was a time when TTP was a 100% fatal disease. For those of you who know the name Jim George, Dr. Jim George out of Oklahoma, he talks about there was a time when you diagnosed a patient with TTP and you said, sorry, go home, get your affairs in order. There's nothing we can do, right? And so now that we have turned this acute life-threatening disease into a chronic one, now what we're seeing is subtleties, these shades of gray that we never appreciated before. We think of TTP as one end of the spectrum where it's ADAMTS13 less than 10% presenting with low platelets, destruction of red blood cells, and symptoms of bleeding or stroke or heart attack. We're also learning what happens when it's in sort of this middle zone. And we see that even though platelets can be normal, even though red cells are normal, patients can have these silent cerebral infarctions with lower levels. So there is this subtlety that we are now learning because before we never had that luxury of seeing a patient with TTP live for another 5 years. So we're not that smart, we're not that good, but hopefully a year from now, 5 years from now, we can say, remember when you asked that question? Now we got the answer. But, you know, we don't know yet, but we, like Yasmin said, we know that ADAMTS13 deficiency is necessary for TTP. You have to have that, but it's not sufficient. And what are because, right, the patients with congenital TTP, they're not in a constant state of TTP. What are the other things that cause it to flare? We know pregnancy, but we don't know all the other things yet. And so,
That's why some of the same hormones.
yeah, so could be, yes.
Hormones do the same thing. They
Yeah.
fluctuate. They kind of mimic TTP stuff. a
Yeah.
little bit.
Yes, ma'am.
In the instance of congenital and immune, we know the atoms drops, right? So what are you looking at, doctors, to determine if it's congenital or immune? Because many of us were diagnosed before somebody even talked about it. So we have no clue what we have because no one ever said.
That's easy. Let me answer. I want to answer it. That's an easy question. It's easy. Yes, yes. That's an easy. Ooh, thank God. Finally, an easy question. Okay, yes. So the question is, how do we determine the difference between congenital and immune? So, as you said, right? Question number one is, what is the ADAMTS13 level? Less than 10%, that's TTP. If there's not an inhibitor, in other words, if we don't find an antibody that is attacking, preventing the ADAMTS13 from working, then we're thinking that's congenital TTP. So when we order like an ADAMTS13 panel, it'll say ADAMTS13, 4%, and it'll give us it'll give us an inhibitor and antibody test. Like how much of this thing that's preventing it from working. If those are zero, if those are normal, then we're thinking this is congenital TTP. And then that's, I don't say it's simple, but yeah, it's a genetic test. And oh, there we are. There's mutations in ADAMTS13 that cinches the diagnosis for congenital TTP. But that's the fundamental difference. And nowadays, I mean, someone should tell you with one blood test whether you have congenital or acquired. Well, right. And so,
They can
so
still test you though.
right. Yeah, we could just, yeah, I mean, yeah, you could find this answer. I mean, where are you from? Okay. Yeah, I mean, you could easily find that out with a blood test in less than a week. If your ADAMTS13 is higher than, if it's 50%, 60%, 80%, then you do not have congenital TTP. And that's the other thing when we're faced with this sort of like, what was it, and you test someone and their ADAMTS13 comes back as normal range, then there's no way that could have been congenital.
Congenital. With a is there any studies that are looking at, hey, is there some type of genetic belief that's present in these people that happen to have what we're calling acquired or idiopathic?
Immune.
So the question is, congenital TTP we know is genetic. In immune TTP, are there any genetic underlying disorders. Great question, actually. So we know that in immune TTP, it's not always idiopathic. You know, we know some of the patients who with lupus actually present with TTP as a first episode and then get diagnosed with lupus. Where I practice in Atlanta, 60% of our patients immune TTP actually have lupus. And 80% of those actually present with TTP first, and then we get diagnosed with lupus. So the initial treatment, in addition to steroids and rituximab, go on to kind of transition them to like a lupus treatment right away, because otherwise a high risk of relapse. And we do that routinely whenever coming to immune TTP. On the background, we're testing to see are there any other immune conditions that we're missing that's driving this TTP. And it's different in different individuals and ages and so on. And back to your questions, are there genetic links? We don't have any great, how do I put this, clear understanding of a gene or few variants that definitely relies it. There's possibly some modifiers that could potentially modify in terms of how often they may have a relapse, yet we're very far away from learning those because those patients are already really far and apart. We're not routinely doing genetic testing in those with immune TTP. But that's something that we will be, in the future, try to better understand why some of them are having more frequent relapses and so on. But yeah. You guys have any other thoughts?
Well, it's, we know that there are certain diseases. You have this mutation, you're getting that disease. Sickle cell, cystic fibrosis, right? But the immune system is so broad and so complex, unless we're talking about sort of immune deficiencies, where a defect in adenosine deaminase leads to an immunodeficiency. When it comes to what causes an autoimmune disease, that's like the holy grail of rheumatology, immunology, of allergies. What is the reason where the immune system, which 99.999% of the time is so good at protecting us, killing pathogens, and not killing us in the process, of all the enzymes in the body, why ADAMTS13? We don't know that answer, right? And as far as I'm aware, I am unaware of any there's correlations that are done with, HLA, I was going to say, yeah, no, but yes, there are correlations done within the Japanese population where they found an increased susceptibility for TTP. And there's another sort of what are called,
there's some correlations in congenital TTP as well. But yeah, go ahead.
Yeah, there's HLA genotypes that are correlated in the Japanese population with an increased risk of immune TTP. In others, there's other ones that are found that maybe with certain infections, but none of this is like, oh, this is the reason why. It's not that. The immune system is so broad, so complex. It's probably innumerable different changes, differences, along with environmental exposures that in this one person switches that allows them to have it.
You have time for about one more question.
Oh, thank God.
All right, maybe the lady over there didn't have a chance to ask.
So one observation before asking my question, is that as far as atypical hemolytic uremic syndrome, people regaining their function. I had one doctor saying you can regain kidney function 2+ years later. And I've actually seen it. I've seen a lot of people 1.5 years, and one little girl just went from ESRD and on the transplant list, or her kidneys working after 3 years, which is amazing. I mean, she actually had a failed transplant, was still working on her original kidneys so a year or so later. But my basic question is coming back to when you discontinue a complement inhibitor or not. I've been in this long enough that I have kind of a predilection for people stay on because I've had my friends die. But what are the different things if you in your practices do take people off a complement inhibitor? What are some of the protocols you have that you would say don't go off, or if you have all these that you might consider? Also, a related question to earlier is how fast do you see AHUS strike?
What was the last thing you said?
How fast do you see AHUS strike?
Oh, okay. Wait, do you want me to go with that? Okay. So the question is, in atypical is atypical HUS or atypical hemolytic uremic syndrome. So the terminology is typically given to a condition where there is underlying complement mutation. Complement is an immune protein that kind of keeps a body under control, actually helps to fight infection, sometimes get activated and starts to attack our own body cells. Primarily, it hits the kidneys the most. So that's why we see a lot of people, children and adults presenting with kidney problems. So the question is, the major question is, there's medication that can use to help to block the complement or the immune activation that can certainly help regain some of the kidney function. And people do really well because it blocks that activation of complement, which is attacking the kidneys. But then the question is, it's a lifelong medications can be given every 2 weeks, every 8 weeks, and the medications coming to the market being tried for. There are several other diseases where the complement is activated. So the big question is now, should we stop or should we continue? Why should we even think about stopping? One, it is expensive. It can be infusions every 8 weeks. They may have to come home, so go to the hospital, or you can have a home nurse coming home to do it. And there's obviously IV lines, and people may get just bored of using medications going through this because many of them get diagnosed during the childhood as an infancy, so having to go through this the entire lifetime. Studies have shown that the younger they are, they're slightly at a higher risk of relapse. Secondly, we know that once you've had a relapse of TTP flare, you're at a higher risk of flares, just like TTP. There's certain genetic mutations. If they have it, the complement is about 30 different proteins, but if there's a genetic mutation involving certain of those, a higher risk of relapse. So we look into all those and see that how likely you're going to have it. Because the challenge is that if you've had a significant kidney damage already, and if you decide to take you off the medication, if you get another flare up, if it damages the kidney, and that'd be quite detrimental to the point that we may have to put you on the transplant list or get you on dialysis. So I think the stopping the complement inhibition is a big question in the community. In the last few years, people have studied this in patients. They've stopped it, followed very closely. It's extremely important to follow them closely. At any moment of them having any flare-ups, they have to go to the hospital or even do some urine testing at home. And understandably that if they have any flare-ups, they get started on this complement inhibition right away. So at this point of time, not many pediatricians are doing it because many of them are higher risk. And also we have we see children as a lifetime risk. They could have additional things that stand up. But there are adult physicians that we have taken them off for atypical HUS. But it's a great question. I think we're certainly learning more and more with these rare diseases of atypical HUS. Are there any other questions that unanswered?
I was just wondering if you had calls for the person who is the ideal person.
Yeah. Yes. Yeah. Yeah. I mean, the extremes always make medical decision making simpler. If it's a child with homozygous mutations in complement and they've lost kidneys and they've gotten a transplant, then no, I would never take that person off. Alternatively, if this is someone, the best case scenario is someone who has no known pathogenic mutation, and this occurred in an extreme shoot situation, right? Some huge, like COVID, someone who had an awful infection, a horrible trauma, and this triggered the atypical HUS. Some of the protocols will say, wait at least a year if there's, to make sure that if they have no kidney functions, they can restore it. And then if the patient is interested in it, that's kind of step number one. If the patient is interested in stopping complement inhibition, then we make sure that there is not, I always like sort of regurgitate what the Hopkins group has put forth because it's a pretty pragmatic approach. If the patient wants to stop complement inhibition, make sure that all the numbers are fine before you even think about stopping. And then you do it weekly, and then twice a month, and then every month, and then every 3 months, you sort of back away from the testing. And you do this because, yes, there will be someone who will relapse. And if you're testing them closely, in some places we'll give them a bottle of urine dipsticks. And they'll say, hey, pee into a cup once a week and dip it. You see any protein, any blood in there, come back in immediately for better testing. And then you almost can always resume that testing earlier, as opposed to waiting until someone is feeling horrible with worsening kidney disease. So it has, I mean, there are many trials that have done this, many centers have done this. Sort of fork in the road, number one is, does the patient want to stop or not? And after that, yes, you just closely monitor and you can do it. I don't say I do it all the time, but yes, after 1 year, this is a conversation we have. That's it. All righty.
Thank you very much.
You're welcome.